Hello, I'm Dr. Pratyusha. Today I'm going to discuss the topic urinary tract disorders in pregnancy. First, we start with knowing the fact that why are females more prone? In females, there's increased chance of urinary tract infection as compared to males because of the short urethra, that is 4 centimeters, close proximity of the external urethral meatus to the areas that are heavily contaminated like the vagina as well as the anal orifice, catheterization and sexual intercourse. So these are the main factors that make women more prone to infections than men. And the incidence of the pyelonephritis in pregnancy is between 1 to 3%. So what is actually happening in pregnancy? What are the physiological changes that are occurring in the renal tract as well as what is the pathogenesis of the infections? The physiological changes. Because of the high progesterone levels, there is a reduce in peristaltic movements of the ureter. Then there is dextrorotation of the gravid uterus, which causes compression of the right ureter, causing dilatation and stasis of urine. So because of the dextrorotation as well as the progesterone levels, the urine becomes stasis in the renal system. And because of the 70 to 80% of the pyelonephritis occurs on the right side, that is on the right kidney, and 10 to 15% are on the left side. And the organisms which are implicated in causing the infection as well as pyelonephritis is most commonly it is the E. coli, which is 70%, Klebsiella, that is 10%, Enterobacter, Proteus, Pseudomonas and the Staph aureus group. So this is the pathogenesis as of the infection, that is the pyelonephritis. This is the image depicting the causes that can lead to pyelonephritis and UTIs. That is and the risk factors. So what are the risk factors that lead to infections? That is the primary gravida, previous history of urinary tract infections which increase the chance by 50%. Presence of asymptomatic bacteriuria increases the chance by 25%, and abnormality of the renal tract is found in about 25% of the patients presenting with infections. So what are the clinical types? Depending upon the mode of onset and the presenting features, the cases can be grouped into asymptomatic bacteriuria, cystitis, pyelonephritis, which can be acute or a chronic type. First, we start with asymptomatic bacteriuria. The term, we define this as when the bacterial count of the same species is more than 10 power 5 per ml in midstream clean catch specimen of urine on 2 occasions, but there are no symptoms of urinary infection. So that is detected without any urinary symptoms. So this indicates actively multiplying bacteria within the urinary tract. And the most common organism that is offending is the E. coli in over 90% of the patients. So how do we detect? This is asymptomatic. So what we can do is we can screen all the patients, all the pregnant women in the first trimester by a urine culture. If the culture is positive, you can treat so that you can prevent further ascent of infection or the pyelonephritis. So what are the complications of asymptomatic bacteriuria? Because of this, there can be lead to hypertension and anemia. There is increased association of premature labor and growth retarded babies is related to the chronic underlying renal condition. And asymptomatic bacteriuria, if recurrent, it is associated with high incidence of urinary tract abnormalities. And there is a higher risk of developing chronic renal lesion in the later life. So these are the complications that can occur in a patient with asymptomatic bacteriuria. And the other things are it can be a recurrent infections or recurrent asymptomatic bacteriuria can occur if not detected and treated. So how will you treat is the antibiotic treatment. We start with the antibiotic course, and if there is recurrence we can also give a suppressive course of antibiotic, that is nitrofurantoin, during pregnancy as per the need. So now we come to acute pyelonephritis. This is an acute phase or a severe infection that is occurring. The onset is acute and it usually occurs beyond 16th week of gestation. The involvement is bilateral, but if unilateral, it is more frequent on the right side as we have discussed because of the stasis and dextrorotation of the uterus. And how was the patient presenting? The clinical features are mainly due to endotoxin release. The biochemical mediators released are interleukin 1, tumor necrosis factor, and endogenous pyrogens. So these cause the symptoms that the patient is presenting with. And the clinical features are the acute aching pain over the loins, often radiating to the groin, and costovertebral angle tenderness, which we can elicit urgency, frequency of urine, dysuria, and hematuria. The fever is high grade spikes with chills and rigors, followed by hypothermia, anorexia, nausea, vomiting, and myalgias. So, what are the complications that can occur due to pyelonephritis? It is ARDS or acute respiratory distress syndrome due to endotoxin release, as well as organ dysfunction can also occur because of the endotoxin release and organ injury. So, how are we investigating? We start with checking the levels of creatinine because there is renal injury, electrolytes, and cultural studies of urine and blood should be done to identify the organism and treat the source of infection. So, what are the differential diagnoses? When a patient is presenting with pain abdomen, that is acute pyelonephritis, what differential diagnosis you should have in mind before you come to a diagnosis? That is acute appendicitis, abruptio placenta, red degeneration of the fibroid, acute polycystitis, labor, and chorioamnionitis. Of these, appendicitis is an inflammatory condition, chorioamnionitis, cholecystitis are infection, and labor that also has to be ruled out before you go to a diagnosis. Complications. The other fetal complications are there may be increased fetal loss due to abortions, preterm labor, intrauterine fetal death caused by hyperpyrexia, and low birth weight babies. Maternal because of the endotoxin release that we have already spoken, it is like anemia, septicemia, septic shock, renal dysfunction, pulmonary insufficiency, and ARDS. How are we going to evaluate this patient? We have admitted the patient, and for evaluation we start with the complete hemogram where we can know the hemoglobin status as well as the TLCs, the tubular leukocyte count, which gives you the idea of infection, electrolytes, creatinine value, renal function test. Then we also go for the dipstick test for nitrate and leukocyte esterase. Then if the culture is positive, what we do is we start with the treat the patient with the antibiotic course, and after 2 weeks we have to repeat the culture. And then you have to also repeat the culture in each trimester of pregnancy. And when there is a pyelonephritis, first the last thing you also have to do is the rule out any obstruction that is precipitating the infection and see that we treat the obstruction. Treatment. How are we treating a patient which is presenting with pyelonephritis? It mostly is a supportive management with IV fluids. Monitor urine output so that it is maintained more than 60 ml per hour. Monitor vitals of the patient, temperature and blood pressure. Then we start with the IV antibiotics, that is cephalosporins and aminoglycosides for 48 hours. Initially this will be an IV antibiotic for 48 hours till we get the culture report, and then we change it to oral therapy for the next 10 to 14 days based on the organism and sensitivity. Management. So antimicrobial suppression therapy is continued till the end of the pregnancy to prevent recurrence. After we treat the episode, we continue the suppression therapy to our pregnancy, and for the suppression we can use nitrofurantoin 100 mg daily at bedtime for suppression of the infection. Then we go with proteinuria in pregnancy. This occurs in 5% of all women. The causes are preeclampsia and eclampsia, urinary tract infections, chronic renal disease like nephritis and nephrotic syndrome, essential hypertension, and the most common thing is orthostatic due to increased lumbar lordosis. There is increased pressure on the inferior vena cava by the uterus or on the left renal vein is compressed by the aorta. So this will lead to proteinuria. It is not definitely an albuminuria because other proteins are also lost in urine during pregnancy. And how do you investigate to find the cause? First, to rule out infection of the urinary tract and the renal parenchymal lesions, you go with the microscopic examination and bacteriological studies. If it is not conclusive, then renal biopsy can be performed. So management is based on the etiology, whatever is the cause. Preeclampsia, eclampsia, we can treat the condition and we can plan delivery depending on the severity. Urinary tract infection, we have to treat the infection. Chronic renal disease, find out the cause and then treatment. Essential hypertension, where we can start with the antihypertensives. Orthostatic proteinuria in the absence of bacteriuria or hypertension is not significant. Then we have hematuria in pregnancy, where it is loss of blood or RBC in urine. So there are few causes which will cause hematuria in pregnancy, that is like those related to pregnant state and those unrelated to pregnancy. Those related to pregnant state are severe infection, that is the pyelonephritis or and along with the cystitis, rupture of the bladder, varicosities that can occur. Then there is following rapid evacuation of urine in acute retention with a retroverted gravid uterus. Lower segment scar rupture involving the bladder or involving the bladder injury. Then operative delivery following obstructed labor due to congestion. When there is an obstructed labor, when we are going with operative delivery like a forceps, then the possibility of traumatic injury to the bladder should also be ruled out. So these are causes of hematuria that can be related to a pregnant state. And those unrelated to pregnancy are the urinary calculi, which can also cause sudden retention of urine, renal tuberculosis, renal neoplasms, and papilloma of the bladder. Treatment of this hematuria is to increase the urine output by adequate fluid intake and correct the cause which is causing hematuria by medical or surgical treatment. Then we have this retention of urine, where there is retention of urine and patient presents with acute pain. So what are the causes of retention of urine? During early pregnancy, it is the incarcerated retroverted gravid uterus. That is, the retroverted gravid uterus which is present is compressing, it is like in the retroverted position and it is compressing over the urethra and bladder, which will lead to retention of urine and impacted pelvic tumors. During labor, associated with abnormal uterine activity, commonly with incoordinate uterine action and obstructed labor. So in these conditions they will present as bladder edema, or we can diagnose it with retention of urine with the lower abdominal swelling which is present. During puerperium, diminished bladder tone, where the tone of the bladder is lost after labor, reflex from vulval injuries which has occurred during delivery, bruising and edema of the bladder neck. So these causes can cause retention of urine during puerperium. So what we should do is encourage the patient to void. Encourage them to pass urine, and if they are not able to pass by 6 hours, it would be better to empty the bladder by catheterization. If the simple measures fail, then catheterization is to be done using a disposable catheter to drain the urine. Thank you.